Welcome, everyone, and thank you for joining us today. My name is Konstantin Alexandrakis, and I serve as head of the Americas region at Russell Reynolds Associates, and I'm speaking to you today from my home in Chicago. And it's a real privilege to kick off today's session with two prominent leaders from the Cleveland Clinic who have generously offered to share their guidance and insights on the topic that you see here, safely navigating the return to workplaces. We're going to spend nearly all of our time listening to insights from our friends at the clinic, but let me start with a couple points on context and objectives for the session. We'll then fully introduce our guests and get the conversation moving. The context and objectives are pretty straightforward. While the pace and nature of workplace return is certain to vary significantly by geography, industry, company, nearly all organizations are confronting two things. One, a daunting task, and two, a dizzying array of advice on the right way to approach that task. So as everyone knows, that's not a great combination. So with those challenges in mind, today's session is designed to support HR leaders by cutting through some of the clutter and confusion. And we'll do that by drawing upon the expertise of some of the world's leading experts in this field. So with that in mind, delighted and honored to be joined today by Dr. Jim Merlino, who serves as the Chief Clinical Transformation Officer at the Cleveland Clinic, and Dr. Stephen Gordon, who serves as the Chair of the Department of Infectious Disease at the clinic. Jim's on the left, Jim's on my left, and Steve's on my right. Jim and Steve are doing work that's at the leading edge of practice in this field, and they'll be covering a wide range of topics during the course of today's discussion. And some of those include offering guidance and perspective on addressing employee fear and anxiety regarding the return to workplaces, preparing the physical workplace and preventing spread of the virus, protocols for mask usage, best approaches for identifying and addressing symptoms should they arise, establishing guidelines for quarantine and safe returns, and they'll also provide perspective on testing, both for the virus itself and for antibodies. They're also very keen to ensure this conversation addresses your most critical questions, so please use the chat feature to submit your questions during the course of the call. Only the speakers will have access to those, so please don't hesitate to ask openly any questions you have that are creating the most concern for you and your organization. With that, I'm excited to turn it over to Dr. Merlino and Dr. Gordon. Jim and Steve, thank you again for joining us today, and thank you for the extraordinary commitment and contributions to all of our health and safety.
Thank you for that introduction, Konstantin. We very much appreciate it. We'd also like to thank Clark Murphy and the rest of the team at Russell Reynolds for having us participate, and for Robert Volt for introducing us to you and the team to participate in this webinar. And good morning, everybody. We appreciate that people are calling in from around the country and around the world, and from Cleveland Clinic. We hope that you are all safe and that you're doing well. We appreciate you joining us today with an opportunity to share updates on COVID-19 and how that affects the workplace. Caring for our community is one of the key commitments of Cleveland Clinic, and our CEO, Dr. Tom Mahalovic, has made the commitment that he wants to help businesses wherever we can get back to work, reactivate the economy so that we can get moving forward and deal with this crisis. Over the last several weeks, we've received several questions, and we've tried to condense those into the topics that we've presented. I will be checking my phone. That's how I'm receiving additional questions from you. So we're happy to take questions as well. We have a website which we'll give you the information on at the end of the conference. We will be posting any question that we didn't answer. We will provide an answer on the website just so that you have the information that you need. So I want to just spend a couple seconds introducing Steve. Steve is the chair of infectious disease here at Cleveland Clinic. He's been on the staff for 25 years. Of note, he did serve as a fellow at the Centers for Disease Control. He graduated from Cornell University Medical College, did his residency at the University of Chicago, and his specialty training at Emory in Georgia. He's been a thought leader in infectious disease and prevention throughout his entire career. He's internationally renowned, and he has been leading Cleveland Clinic's COVID response. And I can tell you that Steve and I knew each other before COVID. We know each other much better now. We spend a lot of time together, and it's been an honor to work with him. So Steve, you're the real star because you're the expert. Why don't we just open it up by talking a little bit about COVID-19 and the pandemic?
Yeah, sure. Thanks, Jim. And again, thanks, Constantine. So, I mean, to level set, I think, you know, if we go back a few months around Christmas time, some of us might have heard about this pneumonia in some patients in a place called Wuhan. And now here we are in May, where the epicenter has moved, obviously, from Asia, from Europe, and now here in the United States. As people know, we're north of 4 million cases globally, which is probably underreported. United States, we're north of 1 million. We're up to over 80,000 reported deaths from COVID in the United States. Having stated that, I think we're also moving from one phase of kind of meeting that burden of disease in patients afflicted with COVID to now trying to, as Jim has said, move toward the next step, what we say, to recovery. And one of the things I think that we've learned here in businesses is, you know, both, I think, preparedness and recovery is a continuous process. We've reacted, responded, recovering. We've adopted that command and control model, which many other businesses have, in trying to be proactively in communication.
You know, Steve, I'm reminded of a comment you made to the executive team a couple of weeks ago where we were starting to talk about reactivating healthcare, right, even before businesses got into it. And you made a comment. Do you remember what you said about...
Yeah, I think it was, you know, we get this. I mean, the principles of infection prevention, diagnostic, in terms of taking care of COVID patients, that is in our wheelhouse. And now I do believe the focus has also been our patients, but also keeping our healthcare providers feeling safe. And as you know, and that's why we're here, a lot of what we have done as a healthcare center, us and others, to keep our employees safe, is now going to be adopted out in the business world. And it's some of the same principles, because I think we've done a very good job at mitigating risk for both our patients and our employees during this pandemic.
And that ties right into what's on employees' minds as they're worried about coming back to work, right? Everybody's fearful, just like healthcare workers initially were fearful to start taking care of COVID. I was rounding on a nurse a couple of weeks ago, and she said, initially we were scared, but now we know how to do this. We've got it figured out. We're fine. What do we tell employees that are coming back to work?
So again, for the employees, I think the 4 principles I think that are being adopted in terms of what I call the horizontal platform for opening of work that are adopted from healthcare. The first is hygiene. That includes hand hygiene, but also hygiene of surfaces. This has to do obviously with how the virus can be spread, a little bit in terms of surfaces, but also protecting our workers in terms of hand hygiene. The second, I think, important thing is social distancing. That's new for us as well. But again, this issue about trying to stay apart from one another, that depending on where you sit in the world, it's either 2 meters or 6 feet. Again, that's influenced by how this virus spread, droplet contact in people without, what would say, source control protection. The third horizontal, I think, platform that's being used in and out healthcare is this issue of masking. And again, this is a new behavior for most of us. Dr. Merlino's a surgeon, so he's used to wearing a face mask in the operating theater. But wearing, in terms of the cloth covering, is something new for all of us. As you know, CDC initially did not adopt universal masking for healthy people in public. That they pivoted in April. And why they pivoted was data-based, meaning that COVID-19 infections, some are a little bit different than flu. Probably for 2 days before you appreciate you have symptoms, you can spread the virus. And so this is a way of protecting others from you if you have inapparent or pre-symptomatic.
So we get asked a lot of questions about why so many tactics. Why can't we just use one or the other? You know, I've just talked about there's this model in safety science, which we use in healthcare, which the airlines use, the military uses, and nuclear power uses. It's called the Swiss cheese model. And if you think about a piece of Swiss cheese that has holes in it as a tactic, and there's events coming at a person to try and cause an error or a safety event, eventually an error is going to hit a patient or it's going to hit an individual worker and they're going to have a problem. But if you line up a bunch of tactics together, you start to create a wall, a barrier with less opportunities for things to go through. And so masking, hand hygiene, right? When you think about social distancing. Each one of those is a piece of the Swiss cheese. It creates a firm barrier to protect people from having exposure to the virus. You know, I think it's important to talk about the difference between droplet and aerosol, right? Because there's a lot of confusion as to how this spreads. Do you want to make a comment about that?
No, I would. I think that, you know, if you go on YouTube and watch someone sneeze, and everyone has done that, you can see this spray. And when we talk about droplet transmission, this is usually what we mean about that 6-foot radius. Most of the infection secretions are going to fall on the ground. Now, can some things be aerosolized? That is, small particles that stay up in the air. That can happen, but that is not thought to be the case with COVID-19. That's true with other infectious diseases such as measles. And when we look at what we'd say the attack rate of measles, it's much, much higher. And so to get transmission with COVID, you need to be exposed, but it's also the level of intensity of exposure. And that's why when we look at the data, the biggest risk of exposure of someone with COVID-19 in terms of their contacts are in the household. And when you think about it, that's whom you're spending a lot of time potentially in shared airspace. Next would be family contacts, and less often will it be at work.
So coming back to masking for a minute, people ask the question, do I need a surgical mask, right? Why shouldn't I have a medical mask versus a cloth mask? Can you spend a little bit more just talking about the differences?
Okay, so I think it's a great question. So when we talk about the cloth mask, this is the barrier mask, and this will keep out most of the secretions. This is also something that is obviously readily available, universal, and it does protect, for instance, in this case, I'm protecting Jim from my secretions. When we talk about what we call personal protective equipment, that's the surgical face mask. And if you look at that technology, it's not just a barrier. There is an ionic kind of prevention in there in terms of electrostatic. But again, when you look at that, you breathe through that mask. It's easier to breathe through a surgical face mask, but it's not tight fitted. Then finally, you get to the respirator, which requires fit testing, and that's for the aerosolization. But I can tell you, it's difficult. You have to breathe through that. That is not something that's durable in terms of wearing all day. So our approach is we do not need indications for the face mask or for the N95 unless you're entering in terms of a patient's airspace where that's indicated. And the cloth mask should be used for our employees, for our visitors in the workspace in terms of to help prevent, to help with the social distancing, and also to protect me, for instance, Jim, from my secretions.
Right. So the important part about masking is we're protecting each other from ourselves so that we're not spreading viral particles to each other in the environment. You don't need to have a special mask. You don't need to have an N95 respirator that the caregivers who are taking care of COVID patients are using.
That's correct.
So let's talk a little bit about symptoms. What should employers and employees look for?
So Jim is getting at that fourth level is screening, right? Screening for symptoms. And again, I think it's important no matter where you are working. If you're sick, stay home. If you're sick at work, go home. And that's the most important thing. It's difficult to know symptom-wise, is this COVID-19, is this something else? But we classically thought that COVID-19 was primarily a respiratory illness, which it is in most people. Cough, fever, shortness of breath. But as we're doing more testing, we're learning that there is an evolving spectrum of clinical illness. Many of you are aware of new loss of smell or taste. There's diarrheal type of presentations as well. Some are looking now at quote unquote the COVID toes, skin lesions, and in the kids, maybe an inflammatory syndrome. But I think the bottom line there is screening for symptoms, which will include fever, cough, shortness of breath. If you're sick, go home. And if you're sick, and hopefully your policies are aligned to support that so the workers don't feel that they're going to get punished or the incents line up. If I am sick, just stay home.
What about the common refrain that people say, well, this is just my allergies? Is there something we can tell that there's a difference between people that have allergies versus somebody that might be suffering from COVID?
So I think the rule is of as a clinician, I've been humbled by this because of the myriad of presentations. It's really would be the new onset of symptoms with that. So if this is not your typical allergies, or all of a sudden you have a different type of headache, then I think for me, The only way I'm going to be able to determine that is with the diagnostic test.
So as we think about, again, what are the tactics, right? So we talked about masking, we talked about hand hygiene, we talked about social distancing, we talked about asking for symptoms, right? Every one of these is an additional layer of protection. What about taking people's temperature? Should we do that?
So temperature taking, as you know, is not everyone with COVID-19 is going to present with a fever, but we do thermal scanning here at the clinic. There are issues, of course, in terms of sensitivity and specificity, but I think one of the major things about this is it also is getting this perception that we do care, that we are screening. And the other thing I think that's important about this method is if someone is thinking about coming to work when they're sick, if they know they're going to get their temperature taken, it might help them stay home. Same thing for visitors or vendors.
So at Cleveland Clinic, we really execute on 5 tactics before we'll let somebody in the building. We take their temperature, we require them to wear a mask, we give them hand sanitizer that they have to sanitize, we screen visitors for symptoms, and we enforce social distancing. So some people do the thermal screening, some people don't. I think most healthcare organizations are doing thermal screening, again, for the reasons that you cited. If someone has a symptom and they're at work, what should they do?
So again, a good question. I think that if someone is feeling unwell, then again, obviously we care about our employees, and then they should obviously get the appropriate medical care, and hopefully, again, whether that's going to go to the emergency department or whether that's going to go home. The next step on that, though, of course, is what next? And I think this is the biggest need here in terms of availability of what we call frictionless Uber testing and test management. Because, for instance, if I all of a sudden get a little sick and I'm with Jim, he cares about me, but he also wants to know now, what do I have? Is it COVID? Because that could inform also different contact tracing, either at home or in the workplace. And so I think this is one of the biggest opportunities, and Dr. Merlino can comment, but this is also a big need for our business partners in terms of they know how to do a lot of the other things, but that access, I'd say, to frictionless testing and test management becomes important, and that helps build the confidence of your workers, as well as your other employees, as well as front of house for those that are public facing.
Yeah, so somebody asked the question, why are we not wearing masks? I should note we are 6 feet apart. We've also been tested, and I can tell you that Steve, I think, has been tested more than a lot of people, and it's not comfortable to be tested, but that's why. But in normal circumstances, we would be wearing masks if we were out in public.
That's correct.
So let's go back to the issue of quarantine versus isolation. Just frame set the difference between the two.
So quarantine goes back to plague ships. It's an Italian word meaning 40. So 40 days was if there was plague in the community, the ships had to stay outside the harbor for 40 days, making sure there were no cases. So when we talk about quarantine, this is not for people that are sick. These are people who may have been exposed. When we talk about isolation, that is for someone who is suspected or proven to have the infection. These domains are really under your local health departments in terms of isolation and quarantine orders. It is not something that, how can I say, the employers are responsible for. And we do have to abide by that in terms of our local health departments for either our patients that are at home or for the employees.
I think you bring up a good point about guidelines by local health departments. Similarly, the guidelines for return to work may vary by state or may vary by country. So I think it's important that people look at those to understand where there's congruence or not when you're thinking about your return to work strategies. So on quarantine, if you are COVID positive, or you're exposed to a COVID positive person, what is the guideline?
Yeah, so the general assault on that will be, say if my spouse is diagnosed as COVID positive in the household, she would isolate, and then I would be, quote unquote, by my local health department, quarantine, meaning 14 days at home. And if I develop symptoms, that would prompt testing. Testing someone without symptoms isn't going to be informative because the incubation period is somewhere between 4 and 11 days. And even in the household, only 5 to 20% of household contacts are going to develop COVID-19. So exposure does not equal you're going to get the disease. As I said, this is not like measles or other infectious diseases that have a very high infectivity.
So when can people come back to work?
So generally speaking, for if someone takes ill in terms of this nature, what we are telling everybody, no matter what they have, is obviously you've got to feel better. In a non-test-based strategy, for instance, by the CDC, if you look at, it's really going to be 10 days after the onset of symptoms or the positive test, and at least 3 days of having no fever off of antipyretics or return to work. And so for us, we've also studied that in our healthcare providers, and we do have a 10-3 kind of rule for our employees that may have gotten COVID. We also add additional masking, but we do the masking. So that's part of our DNA now.
Yes.
So that's for everybody, exposure, COVID or not.
We enforce the masking. We enforce all the tactics. We're very thoughtful about making sure that we hold people accountable to that. Because again, it gets back to no one tactic works, but a variety of tactics together will reduce the risk.
I think, and this is where Dr. Merlino's expertise, because the fifth layer is the culture. And you can have the best playbooks in the world, but if nobody actually believes in it or executing on that, it's not going to go anywhere. And so again, your employers like ours, very intelligent, they want to know the why. We explain the why. And then as Dr. Merlino says, it's more of the nudge than the shaming. I mean, it's more of just like someone said, hey, Steve, your mask isn't all right. It's just a reminder, a buddy system type approach. And again, I do think that type of reinforcement is part of our culture of safety for not only obviously our patients first, but for one another.
Yeah, culture of safety is very important in healthcare as it is in other industries that require highly reliable operating models. And that is where you have people that are not afraid to say, Steve, you should put a mask on. Steve, I didn't see you wash your hands, right? In this environment where little errors can make a difference, where little errors could potentially expose somebody to risk, we all have to be watching out for each other. I think the biggest risk for protecting our workforce is allowing little lapses or allowing people to get comfortable. And one of the things that we talk about all the time in protecting our caregivers, and to date, and this is a wood table that I'm knocking on, to date we don't have a single caregiver that's gotten COVID from being exposed to a positive COVID patient. And we've taken care of a lot of COVID patients. And the thing that we recognize is to continue that trend is that we have to reinforce people the importance of not getting too comfortable with the precautions, right? Because that's when we start to make errors. So reinforcement, leadership accountability, really talking about that culture of safety is going to be critically important. So culture is going to be everything for us.
And we support that. I think, and Jim might also talk about, because many of you have consumers or customers, so if you have these rules, that can become potentially a challenge in terms of your customer base, in terms of also the social distancing, hopefully them wearing masks, the hand hygiene. And for us, I don't know if Dr. Merlino could talk about our visitor policy. It's painful for us not to have a lot of people come and visit. That's been a part of the culture for the hospital. And I think you can comment, but that's probably been the most painful decisions leadership has had to make.
I think one of the hardest things we had to do was limit visitors. We have a very strict visitor policy. People complain about it, but I think generally people recognize that we're keeping them safe, we're keeping their families safe, we're keeping our caregivers safe. There's been a couple questions flowing in about things businesses should be doing. So for instance, at a bank that doesn't have a barrier between a teller and a customer, you should add a barrier, right? A cough screen, plexiglass cough screen. You're seeing that in a lot of businesses going up right now. High touch surfaces, doorknobs, elevator buttons, anything that people touch frequently should be frequently wiped down with a disinfectant and cleaned. People that are touching high touch surfaces, making sure that you're not touching your face, right? Good hygiene practices, using hand sanitizer, washing your hands. You want to think about walking through your business and understanding what's the flow for your employees, what's the flow for your customers, and identifying any barriers that you could potentially put up, any surfaces that you can potentially clean, any steps that you could potentially take away from that flow. Again, we have a lot of resources online that are available to anybody. We'll give you the references for that later. Steve, there's a lot of talk in the news about the statistics of COVID, how many people get it, how many people die from it. I think we're getting a better picture now as the COVID is moving west into Western societies to understand kind of what is the statistics and how many people are getting it and how sick people get. Do you want to comment on that?
No, so another great question. So I think, you know, we're driven by our testing, and to date, as you know, the ability to kind of move into recovery, some of the metrics being used and promulgated by CDC and others is looking at what is your quote unquote doubling time in terms of cases in the hospitals, what's your ICU capacity. So really focusing on what we'd say the sickest and making sure that your healthcare systems have capacity to take care of COVID-19 patients. For most of America, I think we're there. The next then becomes is, okay, as the social distancing is being relaxed, will we see other surges? And is there going to be available other systems for testing to let us know, well, wait a minute, let's pull back a little bit, or let's kind of stamp out these little potential fires. So I think that's to be determined. As I said, testing is going to inform us. We're doing a lot of testing in terms of patients coming into our facility now for non-COVID related things. And based on our data, that's going to inform our practices as well. But I think that also helps create this sense that we are a safe place. And it's important because, as Dr. Merlino can say, there's been a lot of people who have delayed care for non-COVID issues, and that's created a lot of also morbidity and mortality. The strokes, the heart attacks, the delayed cancer care, these are things that march on, COVID or not, and that was the other imperative why we need to continue to open our doors in this sense of mitigating risk for our patients as well as our employees.
There's certainly a lot of fear about getting COVID. I mean, you and I both know a lot of people that have had it and recovered. The statistic currently running is about 85% that get infected either have no symptoms or mild symptoms and never seek health care, correct? What happens to the other 15%?
So this, if you look, this is not affecting everybody equally. In the United States, for instance, the latest statistics would show that our elderly in long-term care facilities represent about 11% of cases, but 33% of the deaths. So obviously, age and associated with that is other comorbidities. And this gets to your issues in terms of what about your employees that may be over 65 or have these conditions that not put them at higher risk for COVID infection, but put them at higher risk for adverse outcome of COVID infection. And in this pre-protection era, before we get the vaccine, effective vaccine, how do you manage that potential fear or anxiety? And is there ways in your organization to maybe keep them from being forward-facing, work at home, or doing other ways to mitigate risk?
So those are some things we don't know. We do know that age is a factor for risk. We do know that comorbidities, chronic medical conditions like high blood pressure, heart disease, diabetes is a risk factor. We're seeing some disproportionate share of certain communities with social determinant issues, access to healthcare, but that is continuing to kind of play out as we watch it. But we know that there are clearly populations that are higher risk than others.
And again, the congregate areas, right? So whether you're talking about a cruise ship, whether you're talking about a long-term care facility, or whether you're talking about prisons or jails. If you look in Ohio, I think probably 15% of all our cases can be tracked to a prison or a jail. And so these are obviously hotbeds for respiratory virus transmission, COVID, influenza, or whatever you want to see. And so these are also been targeted, I think, for screening and prevention methods. A little bit more difficult, obviously, for the interventions that you all are thinking about doing than in a prison. And again, many of us have heard some of the nonviolence are trying to do some early release, but for many of these situations, that's not going to work.
So if you get the disease, 85 times out of 100, you're likely to have mild symptoms or no symptoms. 15 times out of 100, you'll seek health care, and 1% of those will be hospitalized, and then a smaller percent of those will be in the ICU, correct?
That's correct. But the thing from the epidemiology point of view is, even though you might not get that sick, your infection, inapparent or moderate, you can spread to others. And that is I think that's the other concern in terms of control, is why we need the testing and contact tracing. There was a report this week, many of you may have seen, about the choir outbreak in Washington, where it was a choir of 61, generally elderly people, but just one person attending that choir who was COVID positive, didn't know it, and that singing in congregate for 2.5 hours led to 87% of that 61 to subsequently come down with COVID. This was indoors. Obviously, singing is an activity where it's kind of close contact. But if we think about that, those are the type of situations we need to avoid and to mitigate if we really want to get that reproductive number down to 0 and control this before we get the vaccine.
Let's talk briefly about the virus. So the virus is very fragile, right? It doesn't live for days on surfaces like you could read in the paper that it possibly does. Can you give us some insight into that?
Yeah, so this is this is what we say an RNA virus. It's got a lipid envelope, therefore it is, how can I say that? Soap and water, detergents, sunlight, and high humidity. Now, it is true there have been laboratory studies controlled where you can actually have coronavirus last for hours, but that's under ideal laboratory conditions. So, but this is not a spore. This is, this is not something that is going to be extremely hardy, and that's why, again, it's not that fomites or surfaces could potentially spread to contaminate, just like Dr. Merlino said about wiping surfaces. But any detergent, soap and water will eliminate that risk.
Right, so this is very important because we're getting a lot of questions in about cleaning. And so when you take the fact that it's a very fragile virus, it doesn't like light, it doesn't like heat, it doesn't last on surfaces very long, it certainly doesn't like disinfectants or soap. There's a lot of products you can use that'll wipe the virus, that'll kill it. The question about how frequently do you clean common surfaces, it's not defined. Honestly, when you look at the guidelines that are coming out, industries and governments are kind of making some things up as we go. So we say things like frequently. So if you have a high contact surface, doorknobs, elevators, wiping it down probably every hour is not unreasonable. If you're using a computer at work and it's your computer and nobody else is using it, it probably doesn't need to be wiped down at all if you're practicing good hand hygiene. So some of this is common sense, right?
It is, and again, this is all about the fingers, right? Touching our faces with our fingers. So if you're going to do anything frequently, it is really hand hygiene. And obviously surfaces that are grossly contaminated or dirty would be cleaned anyways.
I mean, I remember when this first started rolling out, we were all paranoid, particularly medical people. We would get groceries and my wife would put a clean spot on the counter and a dirty spot on the counter and we wipe down all the groceries. We don't do that anymore. It's really unnecessary. It really can't be transmitted through food. I think what Steve just said, to reemphasize it again, we've talked about it, hand hygiene, keeping your hands clean, keeping common surfaces clean, not touching your face. Those are the things that are going to protect you.
Yeah, and I'd reinforce, there's no indication for glove use in terms of for COVID prevention. And if you think about it, you worry about the person that is wearing gloves and not changing the gloves if they're giving you your groceries or you're giving your other things. So again, we do not recommend routine use of gloves in terms of prevention for COVID-19.
That's great, because a question just came in, what about gloves? In fact, when people come to the hospital wearing gloves, we make them take them off and throw them away and hand sanitize their hands. Because again, if you can get it on your hand, you can get it on your glove. So there's only a couple areas where gloves are important, like food preparation, obviously, taking care of people that are COVID positive, that are potentially infectious. Again, it's another barrier for healthcare workers, but wearing gloves out in the community is not going to protect you. Just good hand hygiene, keeping your hands away from your face is what is going to protect you, along with the other things like masking. Let's pivot a little bit to testing. So before we talk about capacity and availability, I think it's probably important, and we're getting some questions on the different types of testing. So we have swab testing, both nose and mouth, and then we have antibody testing and antigen testing. Do you want to talk about the differences?
I do. So I view this in two big buckets, Jim. So we have diagnostic testing. This tells me the presence or absence of the pathogen. And to date, every diagnostic test is going to require someone to stick a swab somewhere, in your nose, in your mouth. And there's that testing, that diagnostic testing can be an amplification process. We talk about the PCR, or it can be an antigen detection process, or the ABIC, which you've heard about, which is also a non-amplification process. And so that requires a swab. That tells me presence or absence. Let's pivot to the blood test, because I know that that's been out there, whether it's a pinprick or not. This is the antibody test. And by and large, when we're exposed to anything, any infectious agent, if you survive, you're going to develop antibodies. The challenge is right now, there is no validated blood test or antibody test that's going to inform you or a clinician that is a correlate of immunity, that is to say whether you're immune to this or not, or a diagnosis. So the only advantage right now of all the blood tests that are out there today is to inform me about exposure at the population level. So it's not that they don't have any use, but there's no use to the individual. So you've seen what we call the serial surveys being done. There's some done in Ohio, there was some done in New York, and they estimated then, you probably saw that the true number of infections might have been 10 times higher based on the serial prevalence of antibodies to coronavirus. So again, bottom line, our focus is really on diagnostic testing. Now, where are we gonna go with that, we hope? Well, you might have heard about a spit test. That's an easier way of collection, and that has not been validated, but that's a nice way to look at it. But I think the biggest bang is gonna be self-administered testing. And so many of you, if you look at Rite Aid or CVS's, if you drive through them, that's the test you're getting. They give you the box, you do it in your car, and then they send it to a lab afterwards. That, I think, is gonna be our highest degree of being able to get what we call frictionless testing, because it will take the middleman out in terms of acquisition.
So just to reiterate some things, when you read, for instance, Ohio had 50 cases, 100 cases, 150 cases, that's actually identifying the virus from the nose.
That's diagnostic testing, right? Amplification of the RNA, right? So
you have the disease,
yes.
right? Versus antibody testing, which is the blood test, which some people are saying means you've had the disease. But what we're telling you is that the science doesn't really confirm that you've had the disease.
That's correct. So that test is not, it's not going to give you a passport of immunity to go back to work or to say that I am protected from COVID-19 infection.
Part of the problem with the antibody testing, the blood test, is that when the pandemic first came up, started to rise in awareness, the FDA relaxed the standards for validation, which allowed companies across the world to provide these antibody testings pretty much to anybody that wanted them, without really doing the rigorous studying that needed to be done to validate it. I think the FDA is pulling that back now, and they're requiring a little bit stronger validation to make sure that we're not providing false information to people.
It is, and you can see the how could I say, the aspiration to have a test that say, am I immune or not, similar to what we do for, say, hepatitis B or chickenpox. So the reason for having a good antibody test is still there. It's just that we don't have one that's been validated to date.
Right. Lots of questions about the surge. Is the surge coming back? Is there going to be a second surge, or what are we thinking about that?
Yeah. So I think it's a great question. You know, it depends on what you mean by the surge. Obviously, we have not gone through a whole quote unquote season of COVID-19. I think some of the assumptions that I would make is this virus will not go away. It may diminish, at least north of the equator during the summer, because of potential temperature or more distancing that will occur. But the surge that I'm worried about is going to be, again, when respiratory virus season comes in the fall or in the winter. Our other pathogens, such as respiratory syncytial virus and influenza, are not going to go away. And so this creates another challenge or opportunity in terms of testing as we look forward to next year's flu season. And this is why we're also recommending, obviously, get your jab, get your influenza vaccine, and some of the same things that we're talking about in terms of the social distancing, the masking, hand hygiene. This will protect our workers as well as our family members from those other respiratory viruses. So there could be, we could have a silver lining in this, especially if it may be a bad influenza season.
So the other challenge with testing is capacity. And it's not just, it's not uniform. There's testing capacity challenges across the world. Some areas have access to it more than others. Some states have more than others. And that's going to be part of our holdup in terms of getting, better access to understand who has the disease and who doesn't as well, correct?
That's correct. I mean, we want to be informed by the data, and the testing is one way to inform, not just for the diagnosis, but also for contact tracing and how much infection is circulating in your community. And if you think about that, Jim, is we're trying to get back to work, or we're talking about our patients, our friends, our consumers. It's confidence. We can say you're open, but if they don't feel that they feel safe, or there's a mechanism to know if they develop loss of smell or something, that there's a good way to get tested, that is going to prevent, I think, people from actually moving forward. And so I do think it's not just the test, it's the whole test management that goes with it is part of our recovery. And I do think we will see increasing capacity in hopefully the weeks and months to come.
So as we see increasing capacity, it will be more widely available, but now it's really restricted to key areas, people that are symptomatic, healthcare workers, patients, and also starting to manage these spikes. So we talked about the surge, right? And you mentioned that it's probably going to be cluster-based, so micro surges. You might see it in a prison, you might see it in a nursing home, you might see it in a small group that maybe broke some of the rules and spread it. And our ability to contain that is going to be to identify those quickly and test them, correct?
That's correct. That's our, how can I say that? Because it can be an influenza-like illness, but it doesn't mean that it is COVID-19. We still have to think about other potential possibilities. And then, as we said, the contacts. And when we do contact tracing for COVID-19, it's not just the people you've been exposed to since you've been sick. We usually go back 2 days because of that potential pre-symptomatic period.
I think it's important to recognize that there have been tons of models out there that are trying to predict, how big the surge is going to be, how many cases. There really are a lot of models. Some of them have been more accurate than others, I think is a fair statement. But the important thing to recognize is what Steve said earlier, is we understand how to manage this. It's not going to be perfect. COVID is going to be around for a while, but we understand if we do it well, we can manage this. There are businesses that have not stopped operations. Healthcare has not stopped. There's been a lot of information in the lay news about healthcare workers disproportionately being affected. In some cases that may be true, but again, in some organizations like ours, we know that we've been able to protect our workers. So if we follow the rules, we implement the right best practices, we can manage through this. What about treatment?
So treatment is, up until recently and still the only, what we'd say, evidence-based treatment for COVID-19 is supportive care. That might be in the outpatient space in terms of just fluid and Tylenol. On the inpatient space, that might require actually mechanical intubation, fluids, and support. Right now, if we look at our treatment-based, there's one antiviral that many have heard about, the Gilead drug remdesivir. There's been 2 trials which have been mixed, although the NIH trial, which was partially released 2 weeks ago, led to an emergency authorization use, not FDA approval of that drug. We have received that drug and we are treating patients. These are severe sick patients with remdesivir. Having stated that, the Plaquenil that people have heard about is probably not effective. We are in a randomized control trial here, but that has fallen away as other drugs such as antiviral drug called Kaletra. In terms of moving forward, I think plasma people have heard about, so survivors can donate their plasma. That's the non-red blood cell platelet part of your blood that can then be delivered back as kind of passive immunization. We don't know the data on that either, but that is an area of active research. And finally, waiting for the vaccine development, 100 candidates at least. The platform that we look at is probably most out in front and promising is the adenovirus vector. And that maybe if everything goes well, will be widely available in 2021.
So lots of talk about the vaccine, right? What if we don't develop a vaccine? Because it's a tough road for vaccine development.
I think we remain optimistic, but Jim is right. And even if we develop a successful vaccine, you will likely have to have more than one for different patient populations. And then there's scalability, because if we're talking about, no one's ever done 1 billion doses in terms of time, and then there's going to be issues about that capacities. But again, I think, getting back, I think we will continue to live with COVID-19 in this pre-protective phase, no matter how long that lives, how long that goes along. And I think some of these behaviors, we hope, will be a part of our culture and not only protect against COVID-19, but as we said, other respiratory pathogens as well.
More questions about the vaccine. I think the record for vaccine development was the mumps vaccine, 4 years, right?
Well, that's a different time when you had the investigator being able to actually take a swab from his own child and attenuate it and get it in. That's correct. But I would say this, is that these adenoviral vector platforms are based upon prior development of vaccines for SARS-1, which actually went away, also Ebola. So this is the issue about investing in basic science, because This platform wasn't developed overnight. This was based on, obviously, MERS and SARS research, and those labs like Jenner Oxford who did that, obviously, are just using that same platform. So that's a push, again, for investing in basic science research and infrastructure.
So more questions coming in. We're going to get to them as we can. If we don't answer them here, we will post the answers online, currently on our website, which is clevelandclinic.org/COVID-19 at work. We have a FAQ there already from previous webinars, as well as a variety of materials. We'll show you the link at the end of the conference. What about the office environment and whether or not can COVID be spread through the HVAC system?
So we have not seen, how could I say, reports of HVAC system. There was one report, I would say, in a Chinese restaurant where the direction of COVID spread may have been directed toward the air conditioning unit, but again, that was a small study. I think for the office environment, I think what we're talking about, if we do that bundle of care, in terms of your distancing, you will mitigate risk and all the things that Dr. Merlino talked about. That's the best protection. I am not really concerned about air circulation per se or air quality other than what we would worry about normally.
You know, it's interesting. The airlines are kind of a case study, right? Certainly airline travel has come way down since the pandemic, but people are still traveling. And we're not reading stories about people being infected on airlines, right? And so if you think about it, Steve and I had a conversation a few weeks ago and said, I looked at him and I go, would you go on an airline? He looked at me, would you go on an airline? We both said we would, with the right precautions, because of the way the virus is spread. I think that's still true today, isn't it?
That is true today. And airlines do have good air HVAC. The only concern I have on the airline is if they shut that off on the tarmac,
Right.
and there have been studies of influenza transmission when in that situation.
And I know the airlines are working very hard to put the right precautions on to keep people safe. They're studying this and they're putting a lot of effort into it, as well as other businesses. What about feces? What if a food worker doesn't wash their hands and they have COVID? Can they transmit it through food?
So I think what you bring up, I'm concerned if my server doesn't wash his or her hands after going to the bathroom, regardless. I mean, so that's a bigger risk, I think, in terms of this nature. It is clear that the virus, or I'd say some of the viral particles, have been described and identified in different types of body parts. There have been very few autopsies in COVID patients, but it's not surprising that yes, a certain percent you can find viral particles in stool, but that does not portend transmissibility. And again, I think we'd want to all wash our hands as a server, COVID or not COVID, in food preparation.
And we really don't have any known case studies of COVID being transmitted through food at this point.
No, that's correct. SARS-1, there was an outbreak associated with raw sewage in an apartment building. That's not the case. This virus behaves differently than SARS-1.
Coming back to testing, a couple more questions about testing coming out. So first of all, asymptomatic individuals. Any benefit to testing asymptomatic individuals?
So this is a big, I would say, thing in the community, that there's all these people that are asymptomatic. I'd like to reformat that and say, there are many people that are pre-symptomatic and then develop symptoms. And it is true that you can spread potentially in that pre-symptomatic period of 48 hours because the viral load is high. But the fact, are there many people out there, what I call the zombies, that are asymptomatic carriers and just spreading? That probably is not true. And we are also being informed by our own patients that we're testing preoperatively in terms of that, and we're getting very good data. So I think my answer to that is that we don't know the role of what I call pre-symptomatic transmission. That is to be defined. But again, most people are going to have symptoms. They may be inapparent.
And there is a risk that the test may not be accurate, period, right? So there is a small possibility that you take a test on a positive person and it's a false positive or a false negative.
So like any test, as Jim is saying, that's why you need that clinical kind of backdrop in terms of this nature. So many have heard about people getting reinfected or prolonged shedding in terms of this nature. And we have done studies in others. With the RT-PCR, you can detect very small amounts of virus in many patients for a long time. I'm talking about potentially even weeks. But the amount of that virus is significantly lower than when they had symptoms. And that guidance also affected what we'd say a non-test-based strategy for return to work. These people are most likely not contagious.
So right now, employers should not push for testing asymptomatic employees. First of all, there's no capacity for that, right? But other than that, there's really no science behind doing that.
That's correct. Only if you were involved in potentially an exposure or part of a contact tracing.
And again, we know of several case studies, which we will eventually be posting on our website, very large businesses, publicly facing businesses that have put the precautions in place, that have successfully protected their employees, that have not transmitted it to their customers. Again, it's good vigilance to the tactics that we know work to prevent the spread of the virus that are going to protect us.
No, that's just the fundamentals that we're talking about.
So with all of these prolonged stay orders for people to stay home, any risk to our immune system from not going out?
That's a great question. I don't know about the
psychology.
Yeah, about the immune system. But yeah, you know, in Cleveland here, we only have probably 90 days of sun, so to speak. And so, and again, it's interesting when we looked, if you look at cell phone data to track social distancing adherence, and if you look, there were, you know, companies that did that. The Midwest ethics, we were very, very good. The most recent data shows a little bit of leakage, and not surprisingly, that's a lot in our younger adults, adolescent population. So I think this is, you know, the sheltering in place is probably in many areas, as I said, going to be driven by data in the community, but this is not a long-term endured type of non-pharmacologic intervention. People understand that.
Some questions coming in about returning to work, returning from the remote office. And I'll turn over to Steve in a minute to answer. I would add that, you know, this is a new normal for us, right? So we're, again, learning to live with COVID. This is going to be around for the foreseeable future. Ideally, we do have an effective treatment or vaccine in a short period of time, but in worst case scenario, we don't. So we have to continue to be vigilant. We have to think about how we do things differently. So there are likely going to be situations that we want to reoperationalize or think differently about how we engineer our office functions. I know that Cleveland Clinic, for instance, is going through a full evaluation of who needs to come to work versus who can continue to work remotely. And I can tell you also that based on surveys from our people, and I'm sure it's true for some companies, that people are becoming more productive when they're at home or at a remote location. So it is going to be also about finding different ways to do work. Any comments you want to add to that, Steve?
No, I think that's fantastic. And I think, again, it's also about your consumers. So it's interesting because I know there's a lot of bankers on the line. And of course, I can't remember the last time I was in a bank, but then someone reminded me the people that go to the bank are people like my father-in-law. They still like to visit the teller, and these people are over 65. I mean, disproportionately are going to be your highest risk for adverse events for COVID-19. So as Dr. Merlino says, as you walk through your own situation, you've got to make sure that these customers also feel protected and feel secure, because many of them are going to be potentially at higher risk for adverse events.
Yeah, and getting people back to the office or to a bank location, for instance, is again, thinking about what is the flow of the customer, what is the flow of the employee, what do you need to put in place for the customers, marking the floors every 6 feet so they don't stand next to each other, reminding people, signing, providing hand sanitizer when people come in, likewise for your employees. The rules we talked about, masking, hand hygiene, et cetera, enforcing social distancing. I mean, these are the things that we know work. These are the things that other businesses that have managed through the pandemic have used successfully, that have worked. We want to be very vigilant about kind of walking that area to figure out what you need to do. What's the current thinking about schools this fall?
Another great question. So, you know, if we look at the schools themselves in terms of the social distancing, it's estimated that school closures represent about 40% of the social distancing bucket. And as you know, children have not been front and center in terms of clinical disease. It's not that they don't get infected. In fact, when we look at a country like Iceland, they do get infected as much as other people. They just don't get as sick, which is fortunate. But again, how do we manage that? And different strategies. Sweden, as you know, never closed the K through 6th grade. But other places, as we look at colleges, Cal State system just announced yesterday that they're going all virtual primarily for next year. And so these are ongoing discussions. And I think for those of us that remember our school days, you know, you can do some things with children, but they're going to get together. And so these are discussions that are ongoing in terms of what is your tolerance for risk, being very transparent, trying to, as we said, mitigate the risk, but understanding that when you're talking about kids, even if you split the classroom staggered, have online classrooms, is that there's still going to be, it's not going to be no risk.
Right, and it's interesting when you think about how we shut down society, right? It was the big gatherings first, down to, you know, stay-at-home orders, and now when you think about how we're ramping back up, it's the reverse order, right? Relaxing stay-at-home orders, probably the big gatherings are the last thing that we're going to tackle as we think through how to do that safely. I think we're coming up on the last 5 minutes. Constantine?
Jim and Steve, that was super helpful, and a lot of good information and facts, which is what we need. We need as many facts as we can get. And as Jim referenced, I want to note that the Cleveland Clinic has generously made available a rich collection of resources on the topics we've addressed today. A number of things beyond the scope of today's session. You'll find all the information on the site that's noted here on the screen. We'll also follow up with an email that includes a link to the clinic's resources. We also hope that you will join our next section in the HR Leadership Series next Friday, same time. We'll hear the perspectives from a stellar panel of CHROs from Google, speaking of Gilead, Neiman Marcus, and Coinbase on the role of HR in leading through and beyond the COVID crisis. But most importantly, let me close by expressing our deep gratitude to Jim, Steve, and the team at the Cleveland Clinic, and all the healthcare workers who are exposing themselves to great risk as they work to protect all of us. Thank you for your contribution and commitment. We're enormously grateful for all your work, and thank you for everyone on the line for joining today. Please stay safe and healthy.
Thank you, Constantine.
Thank you, Constantine.